Mm-hmm.
Okay, will you start to introduce?
Yes, dear colleagues, dear friends, the pediatric section continue the program of the webinars, which this year was enlarged. This year we plan 4 webinars. So for these webinars, we have chosen the topic of Syringomyelia. So the next will be on the 14th of June. It will be devoted to the differences in the vascular diseases in children and adults. And after this, we also we are planning to another webinars. One of them devoted to the oncology, and the next one to the treatment of the cerebral palsy. We have chosen the topics according to our main mission of the pediatric section. So the comparison of the same diseases in the childhood and in the adulthood, in order to inform our adult neurosurgeons about the peculiarities of the diagnostics and the treatment of the same diseases in childhood, which they know in their adult patients. So this is our webinar devoted to the Syringomyelia in adult, in children in different ages. And it's a great honor for me to introduce our 2 moderators, the Federico De Rocco and Marianne Jokler. So please, dear friends, we may start. Federico, Marianne, please.
Thank you very much, Sergey. So it's a great pleasure and to have you here, all of you, with this great topic. We try with Dr. Euler to have the best speakers available on this matter through Europe. So you will see different points of view, different elements discussing about the Syringomyelia. So please, Marianne, if you want to have a few words.
Thank you, Federico, and thank you for this comprehensive introduction, Sergey. As you mentioned, it's essential that the pediatric section webinars are conducted jointly with another of the adult ENS sections in order to achieve exactly bridging between adult and pediatric neurosurgery. And this afternoon, it is our pleasure that this webinar is a joint session between the ENS pediatric section and the ENS CSF section, soon to become, or ENS CSF task force, soon to become the CSF section. And it is my absolute pleasure to introduce our first speaker, Professor Dominic Thompson from the UK, to speak on Syringomyelia and the ependymal canal. Thank you.
Thanks very much indeed, Marianne and Federico. So let me just share my screen there. Is that working?
Yes, that looks fine, Dominic.
Thank you very much then, Marianne. So, well, welcome everybody to this evening's session. So this is really just some introductory thoughts, I thought, just to, I suppose, set the scene of Syringomyelia. And I think importantly, just to be sure that we're all talking about the same terms and we understand some of the nomenclature around this topic. As many of you will know, the term syrinx comes from the Greek myth written in Ovid, and Syrinx was one of the nymphs, and she was pursued by Pan, you can see her, who comes and tries to grab her from the banks of the river Styx, but her sisters turn her into a hollow reed, and that's where we get the term Syrinx, and it's the same as syringe. It basically means a sort of a hollow structure. But not necessarily all hollow structures when it comes to the spinal cord represent a syrinx. I'd like to present to you a couple of scenarios, 3 scenarios. First of all, case 1, a 9-year-old child. Yeah, this would be a typical referral to pediatrics. Spinal pain, has a normal neurological exam, but has an MRI scan which reports a thoracic syringomyelia. On the right, we've got a second case, a slightly older child, 12 years, also has spinal pain, but this one has a scoliosis, and you can see that slightly from the MRI. And again, the MRI reporting, as you can see from the arrow there, a thoracic syringomyelia. And then finally, we've got a third case, yeah, a 13-year-old, yeah, also with scoliosis, yeah, but completely normal symptoms, no pain, but an MRI report with cervicothoracic syringomyelia. And I guess the question is, should these have all got cavities within the spinal cord? Where is the clinical relevance? Can we differentiate easily between those to make a sensible way forward when we're assessing children? If you look at the textbooks on the pathogenesis and the history of syringomyelia, it gets incredibly complicated. And Dr. Broadbelt, who's going to be speaking to you after, will probably be able to update you much more on the pathogenesis. But broadly speaking, the theories have really been divided over in 2 ways. Is it a hydrodynamic problem where basically CSF is pushed down through the omex into the central canal of the spinal cord? And this was the theory proposed by Georges de Boulay and Gardner many years ago. However, a more contemporary theory is that the origin of the CSF, rather than from being within the neuraxis, is from without, and that there's a pressure gradient that gradually forces CSF along the perivascular spaces. You get either obstruction or turbulent flow in the subarachnoid spaces. This pushes CSF into the spinal cord. But of course, normally, and again, particularly in the neonate and the child, yeah, the spinal cord is embryologically hollow. There is the central canal of the spinal cord, sometimes known as the ependymal canal. Yeah, this is often quite evident at birth, but becomes less obvious. And so certainly by the time one's into the adolescent and adult years, much less commonly seen. But this, for example, is why we see occasionally referrals for a so-called terminal ventricle like this, which is basically a hollow remnant, if you like, of the terminal spinal cord, and an entirely benign condition that requires no treatment and no follow-up. So the question really is, yeah, when is a syrinx not a syrinx? And I guess the answer to that is, in my opinion, when it's a hydromyelia. Yeah. Now, the term hydromyelia is very pejorative, and I think there are a lot of synonyms out there in the literature that I think you should be cautious of. The terms idiopathic syringomyelia, hydrosyringomyelia, isolated syringomyelia, yeah, these I think are confusing terms because they lead you to think that there is a grey area between syrinx and hydromyelia. And I think from a practical point of view, this is actually not the case. They generally are fairly distinct cases and can normally be easily separated on radiological grounds. So I would avoid using these terms that have the word syrinx anywhere within them. So what are we talking about when we look at hydromyelia, and how can you distinguish it from a syrinx? The thing about a hydromyelia, it is typically primary. It is occurring without any associated anomalies, Chiari, history of trauma, infection, tethered cord, and so forth. So that's number one. The second thing is it is classically central, and it's worth looking at the axial T2 MRI, and you see this very central the placed cavity in the spinal cord. And the third thing is they are much more typically thoracic than cervicothoracic or lumbar, not exclusively, but I would say typically. By contrast, look at syringomyelia. Syringomyelia is characteristically secondary. Yeah, there is an underlying predisposition. Yeah, and if it looks like syringomyelia on an MRI scan and you think of it is, then you really should be looking for an underlying spinal cord. On the axial T2, like these, you can see that unlike the hydromyelia, the cavity is very much more eccentric. It's extending towards the surface of the spinal cord. And of course, this fits in with the pathogenesis of Oldfield and others, where perhaps the route by which CSF gets into the spinal cord. And many of these will extend into the cervical region, particularly in the pediatric population. And unsurprisingly, these are different histologically. The hydromyelia is really a dilatation of a physiological structure, or a persistence of a physiological structure, and would be characteristically lined by ependyma. By contrast, the syrinx is typically eccentric, it's pathological, and will have a more gliotic type lining to it. So in order to try and distinguish between the ependymal canal, hydromyelia, which I think is a reasonable term, and the syrinx, syringomyelia, yeah, I think you can look at these 4 S's. The site, yeah, thoracic versus cervicothoracic. The size, yeah. In hydromyelia, it's unusual that the cavity dramatically distends the spinal cord. You will often see CSF spaces around the area of the hydromyelia, whereas in a syrinx, you can often see the spinal cord much more dilated, and sometimes the subarachnoid spaces can almost be completely obliterated. The shape of the cavity, again, typically round in the hydromyelia, but more typically ovoid in the syrinx. And the setting, yeah, the background in which this happens, again, hydromyelia, almost by definition, has no associated pathologies, whereas the syrinx, as I said already, relates to something which is secondary to some underlying pathological process. So what do we do if we see a child we've diagnosed a hydromyelia? Yeah, does it ever require treatment? Should it be followed? And there have been a couple of fairly large papers that have looked or tried to investigate the natural history of this, because there's often the question, should you repeat the MRI scan? Well, in both these studies, they did that. And as you'll see, this looks at what happened to the hydromyelia when the scan was repeated beyond an interval of a year. And you can see that in the majority of cases on the right, in both these papers, in the Joseph paper, yeah, over 90%, it didn't change. And in the MAG paper, 62 didn't change, but that's because 25% of those actually got better over time. And in both of these, yeah, the incidence of progression was incredibly low, none in the Joseph paper. And even in the MAG paper, where there was progression, in none of those was it associated with a clinical change or a need to intervene. So the suggestion is that in most instances, yeah, this is a pretty benign entity and therefore questionable value in surveillance imaging. It's not always absolutely black and white, as medicine rarely is, and you'll see this case and you can sort of test whether this is hydromyelia or syrinx. So this is an 8-year-old, yeah, who had an MRI for a frontal headache that subsequently got completely disappeared. There were no Chiari features on clinical assessment, no associated scoliosis, and a normal neurological examination. And you can see here, there's not really a Chiari. I mean, you can see the tonsils are probably at or just above the foramen magnum, but there clearly is fluid in the spinal cord, but it's very sensual. It's much more hydromyelic in its appearance. And of course, this child, being asymptomatic, was followed, and you can see that a few years later, actually, all this is completely resolved, and certainly on the axial imaging there, again, it's very much looking much more like a hydromyelia picture than a syrinx. What about the association between syrinx and scoliosis? Yeah, we all know that Chiari can give you a syrinx that can cause scoliosis. But what happens when you have these cavities within the spinal cord? Often the radiologists will call them syrinxes, which are associated with the scoliosis, but there's no Chiari. Yeah, is there an association here? There was an Australian called Dan Greitz, who was writing about sort of 8 to 10 years ago and wrote these papers, and who suggested that this could probably be explained on the basis of local turbulence. And I think this does fit in with some of the experimental evidence of Oldfield. Again, this external disturbance of CSF flow, because in the presence of a scoliosis, yeah, the flow of CSF around the spinal cord becomes turbulent. You get pressure dissociation across the apex, and that can cause a transependymal or transmantle pressure gradient across the spinal cord, yeah, that leads to cavitation of the spinal cord. And so you can get these cavities that may be a consequence of the scoliosis rather than a cause of it. As I say, this is theoretical stuff rather than practical. But what I would say that in most instances, if you see these cavities occurring in the context of scoliosis, typically I regard them as either incidental, yes, or secondary rather than primary, as I say, a consequence to local aberration of CSF flow, and they do not require intervention. And secondly, they do not increase the risks of scoliosis surgery. There's no evidence that if you operate in the presence of one of these cavities, that it changes the neurological prognosis of the surgery. So in terms of the hydromyelia, yeah, my personal follow-up regime here, I see them for clinical review. I generally reassure if those MRI characteristics are confirmed. I have a standardized response to the referrer explaining that this is a benign. I often quote those papers. I do not recommend follow-up MRI scan. I certainly don't recommend contrast examinations in these children and wouldn't follow up unless, of course, there are any new or progressive symptoms, which, as I say, in my experience, is incredibly unusual in these cases. Syringomyelia, of course, very different. There we have an obligation to define the underlying cause, which in children, you'll be much more looking at things like Chiari abnormalities, dysraphisms, maybe occasional tumors, yeah. Things like post-traumatic syrinx, post-inflammatory syrinx, a little less common in children than you might see in adults. So I guess to come back to my three cases, yes, those where you see these cavitations that fulfill all the criteria of a hydromyelia, but not a syrinx, I think can be safely reassured and no treatment or intervention required. By contrast, of course, as we said earlier, that association between Chiari, syrinx, and scoliosis, we know that surgery at that point can certainly improve the syrinx and can, if performed early enough, affect the natural history of the scoliosis. So to summarize, I would argue that hydromyelia and syringomyelia are radiologically and pathophysiologically very distinct entities, and that they can, in the vast majority of cases, be easily distinguished on conventional MRI sequences without having to do flow studies or anything like that. And I think you should avoid the terms idiopathic hydromyelia or hydrosyringomyelia, because I think it just confuses rather than it illuminates. And I would suggest that you consider hydromyelia as a benign variant with a good natural history. By contrast, clearly syringomyelia, a pathological state with a known cause, and it's our job as neurosurgeons to identify and treat that underlying cause. So Marianne, thank you very much indeed. I hope I've kept reasonably to time.
Absolutely. I think we could recommend that questions are put via the chat at this point in time and maybe answered later. And Federico, will you take over with the next speaker?
Yes, so for the audience, we will have two talks and then have this common discussion at the end. So please, Dominic, stay with us if you can. After Hans' talk, so we have Hans Delier will discuss about the assessment he does, and we'll answer all the questions that you will put on the chat, question and answers later on, and all the questions from all the other speakers, of course. So thank you, Hans.
I'm not muted anymore. Can you see my screen? Is the presentation visible? Okay,
Yes,
great.
yes.
All right, so let's talk about the assessment of Syringomyelia. So first and upmost are the clinical symptoms. So what clinical symptoms can you expect with this? Typically, there's talk about dissociated sensory loss when we're looking at sensory symptoms and signs. And that's actually because when the syrinx starts more or less centrally in the medulla, it will damage the spinothalamic tract. leading to a state that pain and temporal sensations are lost, and most of the time in a cape-like distribution. So the arms, shoulders, upper body, often as asymmetric, as a true Syringomyelia, like Dominic told us, is mostly asymmetric. Patients may also experience pain and abnormal sensations in the neck and the shoulders or in the hands. And initially, when it's still small, it spares the dorsal column and the medial lemniscus. So the pressure, vibration, touch, proprioception remains intact in the upper extremities. Looking at motor problems, that mostly starts a little bit later on when the centrally located syrinx will start to extend, and in an early state it will damage the ventral horn motor neurons and the fibers from the central, and then the thoracic, and then the lumbar, and then the sacral parts. And in a late state it will involve the lateral and anterior corticospinal tract. So in the beginning, the early symptoms will be those of lower motor neuron loss, being wasting and weakness of the more distal muscles of the fingers and the hands. And if you would test them, diminished reflexes in the upper limbs. And later on, when the lateral anterior corticospinal tract can get involved, you can actually get a mixed lower upper motor neuron loss, having wasting and weakness in proximal muscles of the shoulders and trunk, but also spasticity in the lower limbs. Less common, you can have symptoms and signs from the brainstem, and then it's called syringobulbia when the syrinx would extend to the medulla oblongata. And then you have early symptoms of lower cranial nerves, dysfunction, coughing, aspiration, dysphagia, voice problems. And it's often difficult to distinguish what symptoms are related to the the resultant syrinx and what symptoms are, for instance, related to the Chiari malformation. Another presentation is, of course, scoliosis, as Dominic told us. It could be an effect of the compression of the anterior horn cells, resulting in an unequal weakness of the paravertebral muscles, and then scoliosis can start and can progress. Typically, scoliosis in a young age with an atypical curve, rapid curve progression, and back pain associated with scoliosis. Those are red flags, and then there should be a screening for the presence of syringomyelia. Chronic pain is a difficult one. There's a lot of pain syndromes related to post-traumatic syringomyelia, but the problem is that once the syrinx is surgically successful treated, meaning that it reduces in size, still often the pain will remain. So most of the time the pain is more related to the initial injury and the injury that the medulla has subsided instead of the syrinx compressing. So what diagnostic tests can we do? Plain X-ray is only for scoliosis assessments. Neurophysiology is not routinely done. You could see that SEPs and MEPs would be different, but it's not a really routine thing to do. The golden standard is MRI, like Dominic already showed us. It's the T2 weighted images would show a dilated cavity with a CSF-like intensity. And MRI is then also used to determine the primary etiology. And it can also be detected, it can also be used to detect abnormal CSF flow. So let's look a little bit further down there. So to detect the primary etiology of a secondary, so a real syringomyelia, is the main question is actually where is the CSF flow obstructed? And then there are different possibilities. Could be intracranial, could be an hydrocephalus, leading to a secondary obstruction of the craniovertebral junction, or it could be primarily the craniovertebral junction itself, like a Chiari malformation or arachnoid scarring due to birth trauma. A large group of problems could be the suboccipital spine, so post-infectious or post-hemorrhagic adhesions due to a trauma or due to some bleeding. Arachnoid cyst or reps, tumor-related, Thetford cord. And then there's the so-called idiopathic syringomyelia, which Dominic told us not to use this term, and I think he's right, because it gets a little bit confusing, and when you read the literature, people tend to use it for different types of problems you can see in MRI. So in the idiopathic, it's clearly there is no clear etiology, and so you can try to define whether or not there is some space of some location of CSF flow obstruction. So what about MRI findings in correlation to symptoms? Because one of the problems with the syringe is to see whether or not the sometimes very subtle complaints are related to the syringe. And as Dominic showed us in Syringomyelia, more than 90% would actually decrease or stay stable. And then it's even more difficult to try to figure out if there is any symptom presented by the patient or by the parents of the patient related to this thing you can see on MRI. So the anatomic MRI imaging is only giving a quantitative assessment of the tonsillar herniation and the posterior fossa and the intracranial volumes, and it can clearly show a difference between the chirality patients and controls, but the morphometric differences are actually poorly correlated to the severity of symptoms or the occurrence of syrinx. So it could be a huge chirality, and still it's impossible to predict whether or not there's going to be a syrinx or whether or not if this is going to lead to more complaints. And if you see a syrinx, even the size of the syrinx is not directly correlated to the amount of complaints and problems patients may occur. So a whole new set of MR techniques has been developed already for some time, and there's a very nice review just recently printed. It's down there, so I would advise you, if you like to read about it, to read this. And these are called the dynamic MR techniques, in which you can actually evaluate the CSF, but also the tonsillar motion, so the motion of the brainstem and the tonsilla. So it's a cardiac gated CNF phase contrast MR. That's the mostly used one, and it's based on averaging. So it actually makes images gated to the cardiac cycle, and it follows 4 or 5 cycles, and then it makes some kind of averaging, and then you can actually see where the flow is going. So because it's an averaging technique, it will not give you the visualization of the influence of the respiratory system. So you cannot use this to evaluate a Valsalva or Valsalva-induced headaches, etc. If you want to evaluate that, then you can use real-time phase contrast MR techniques. These are increasingly getting more and more used, and it allows the evaluation of respiratory changes, but it's not that easy to perform, and it's somewhat cumbersome to get good results, and you need good cooperation of the patient as well. So what MR findings can be correlated to symptoms? Can we use these types of imaging to correlate symptoms? And actually, when you look at the CSF motion and the brain motion between normal and chirality patients, then there's a clear difference. And some studies have shown that the CSF motion is related to the symptoms. So the more this is disturbed, the more you can have symptoms. And the CSF motion is also independent, a predictive factor of the success of decompressive surgery, meaning that if you see a normal CSF flow around the brainstem, and even if there is a chirality, then this is actually a negative predictive factor, and chances are rather high that decompressive surgery will not result in solving the patient's problems. On the other hand, even without clear chirality malformations, but there is a clear disturbance of the CSF flow around the cervical junction, this would actually mean that there's a high chance of solving the patient's problems by doing decompressive surgery. So that is kind of clear. It is, sorry, just go back. It's less clear if you're looking at the motion of the brainstem and the tonsillus. There are different reports stating that the more movement there is, the more the symptoms, but there's also papers stating the opposite. So up to now, only the movement of the CSF around the cervical function is more or less reliable. And then the differential pressure in the syrinx versus the subarachnoid space can be examined with these techniques as well. And actually, it sheds some light on the pathophysiology, like Dominic told us already. What they see is that there are lower systolic and diastolic velocities within the syrinx cavity than in the subarachnoid space. So there is a difference in velocity and probably a pressure gradient. There's a higher systolic than diastolic velocity in the syrinx. So the pressure wave fluid enters the syrinx faster than it gets out. So that could also point towards how the syrinx can distend. There's an early systolic peak in the syrinx cavity compared to the subarachnoid space. So the timing of the peak is also of importance, because that has been shown in experimental work that if there is a delay in the peak flow between the central canal and the subarachnoid sinus, this could cause some dilatation. So there's pretty much good data coming out and getting better about the CSF movement, but there's conflicting data and evaluation. So to conclude, I'm very sorry, but it's getting very loud around my ear here. The clinical examination is key to link the complaints to the syrinx. MRI of neurexis is necessary to find the etiology, and dynamic MRI can help in difficult decision making by evaluating the flow. And those two articles I put there, the utmost Flint is a nice review, relatively recent review about the entire Syringomyelia and the vision about it and treatment, etc. And the reference at the bottom is very interesting if you want to know more about CNA MRI, dynamic MRI. Thank you.
Thank you very much. And unfortunately, at the end, it was a little loud on the background, so it was difficult. But so we can start the discussion on the questions. So one question we have for all of you is from Samira Akmal, asking about the lining of ependyma in the different cavities. So in the hydromyelia or in the Syringomyelia, do you have differences in the tissue? Maybe Dominic, you can answer that.
Yeah, thanks, Federico. I mean, I guess most of the time we don't biopsy them, so it's difficult to answer that question with certainty. But as I was trying to show in those slides, almost by definition, the hydromyelia will have an ependymal lining. By contrast, because of the pathophysiology of syringomyelia, which is a pathological ingress of fluid into the cord, there the lining is more likely to be glial. Now, that's not to say you may not find some disrupted ependyma within that, but it's predominantly glial in the syrinx and ependymal in the hydromyelia. That's, I guess, the most accurate I could give you.
Okay. So there are also some questions about Chiari and syrinx. So with or without scoliosis. So without scoliosis first. So in the case you don't do surgery, do you follow them? Do you repeat imaging to see if the syrinx progress?
So for me, I must admit, if I see Chiari in the presence of scoliosis, yeah, for me, it's only significant if there is a syrinx present. I think if you have a scoliosis patient with a Chiari, but no syrinx, I must admit, I don't think there's any evidence there to support the correlation between the Chiari and the scoliosis. I think if there is a Chiari, a syrinx, and a scoliosis, yeah, there I do operate, but my prognosis in terms of improvement of the syrinx will be dependent on different scenarios. So the classic patient who tends to benefit is the young child with Syringomyelia associated scoliosis, who's pre-menarchal, who's got a curve of less than 30 degrees. And that's work that came from Doug Brockmeyer and the group in North America. And I think those you can definitely improve the natural history of the scoliosis. But for me, scoliosis in the presence of Chiari and syrinx, even if there are no symptoms, I think there's a cogent argument to consider surgery there.
And the surgical procedure would be?
So my classic, I mean, again, you know, I know Gianpiero and I had an ISPN debate on this, and if anybody wants to have a look, it's on the ISPN website from when we did that. And of course, the reason was the debate is there is no absolute consistent. My personal view is that I open the dura because I think at the end of the day, you have a functional obstruction at the level of the craniovertebral junction. And I think when you see an improved CSF cavity behind the tonsils, you can then be much more reassured that you are going to get improvement in the syrinx and resolution of headache symptoms if you have them. So for me, I am a dural opener, but I know, for example, Luca and the Rome team, they tend to preserve the dura. So yeah, I must admit I'm a dural opener because I think you get a much more predictable decompression of the syrinx. Plus, but I would say when I open the dura, but definitely with a duroplasty. There are groups that just widely open the dura and then close the muscle over the top. For me, I wouldn't do that. I think you're opening yourself up to a lot more problems post-operatively.
You are unmuted, Fede.
Thank you, Luca, for I was talking just to myself. So you mentioned at a certain point that you can have scoliosis and a localized syringomyelia without the Chiari.
Yeah.
That those cases, the hydrodynamic problems are localized due to the scoliosis, and the consequence is the syringomyelia, the localized problem. How do they evolve after correction of the scoliosis? Do we have studies in which they were able to do MRIs despite the osteosynthesis and assess that the syringomyelia was solved by correcting the spine deformity?
I don't know the answer to that, Federico. What I must admit I do is that there are two very, very large North American studies where people have just done the scoliosis surgery without doing any MRI beforehand. Yeah. Now, and some of those, I think there are like 2,000 or 3,000 patients in some of those series. Yeah. So almost certainly some of those are going to have had hydromyelias, cavities within the cord, and they argue that the MRI in those series didn't make a difference to the neurological risk of the surgery, because that's the thing the orthopedic surgeons often worry about. In operating in the presence of a cavity in the spinal cord, is that increasing the risk of surgery? And I think for those focal changes in the spine, I think the answer that I don't think there's any evidence for that, but I can't point to post-operative MRI studies to support that.
Okay. So there was one more question, last question. When do you recommend surgical approach? Luis Carius, can you precise in the chat surgical approach for what? And there was a question, what type of surgery do you offer for syringomyelia? I mean, isolated syringomyelia, what about the drainage?
So I must admit, again, I don't like the term isolated syringomyelia or idiopathic syringomyelia, because by definition, syringomyelia is not idiopathic. It has an underlying cause, and it's your duty to try and find out what that cause is. Certainly, I have had cases where I've had a bad, say, Chiari with syringomyelia. I've done what I felt was a good decompression. I've got an MRI showing what looks to be a capade, and yet the syrinx has persisted or even got bigger. And I think in those cases, I have, and Shlomi Constantini has written on this about the possibility in those cases, yeah, doing a syringo subarachnoid shunt in those. So I think that is an option for refractory cases. But I absolutely emphasize that is something that I have never done, and I couldn't imagine a scenario when I would do that in a hydromyelia.
Hans, you want to comment?
I just had only one case, so I have no big experience, but there are some recent reports by the group of Sinali and other groups advocating the placement of a fourth ventricle subarachnoid shunt in those cases, which apparently gives a good result. And I have this one Noonan patient which had a Chiari, and I did the decompression. I did a second decompression, and still, although there was plenty of room, there was normal CSF on MRI, it remained. And when I opened, I still found some arachnoid scarring. So I put in the drain, the fourth ventricle, to the level of C2 subarachnoid space, and problem was solved for many years. So I think this might be a solution in extreme cases.
Okay, so the question about Lucas was Syringomyelia, do you recommend a shunt? But I think that you mentioned the possibility of the Syringomyelia shunt, Dominic. There was another question regarding sclerosis and Syringomyelia. Don't you think that the cause is due to asymmetrical constraint? So this is from Seita. So the occipital region, some asymmetry, and causes the scoliosis and Syringomyelia.
Yeah. Sorry, I wasn't quite sure of the question there, Federico, because certainly I have seen somebody postulate, and again, I think it was actually in one of Doug Brockmeyer's papers, that you could have asymmetric compression of the tonsils on the brainstem, and that could somehow change motor function and cause the scoliosis without a syrinx. I must admit, I have not seen that scenario, and as I say, I would not operate on a Chiari for scoliosis in the absence of a syringomyelia. That would be my personal view.
Okay, so I think we need to move on because Sergey recommended us to be on time.
Federico, just one final comment, and again, just because I think it's very pertinent to pediatrics, and that's if you have a scenario of this and they don't improve, one always has to consider the possibility of an underlying hydrocephalus or CSF disorder, and because ETV and ventricular shunts can have a role occasionally in these cases. Sorry, I just meant to put that in just because it's relevant, I think, in a pediatric forum.
Exactly, don't forget ETV can treat some caries.
Exactly.
So, Luca, it's thank you. Can you continue?
Yes, of course. Thank you, Federico. I'm trying to share the screen. Please let me know if you can hear me properly, and especially if you can see my screen properly.
Yes.
Okay, thank you. So thank you again to you, Fede, to Sergey and Marianne for organizing this meeting. I hope it will be the first of a long series of the ENS and ESPN meeting conjoined. Also for inviting me to talk about one of my favorite topics, and I believe that we concerning the indication for the treatment of evolutive syringomyelia in children, we should consider not only the compression, the tethering, and the direct approach, but also something else. First of all, it is important to define define the syringomyelia and the etiology, but fortunately, Dominic and Dan's have done this job very clearly, so I can skip these slides. It was just to recall what is the symptoms of an evolving syringomyelia, and of course also what are the pictures that we can have for an evolving syringomyelia associated in this case to Chiari malformation. So I will start my presentation from here, starting from the consensus conference, the international consensus conference we had in Milan 4 years ago, because the considerations I'm going to do in the next slides reflects the opinion also of the experts who came to Milan and gave their opinions. But also, of course, they are based on the literature review that we made in preparation of the consensus conference. So, a first option for the treatment of evolving syringomyelia is the decompression. And this is usually concerns the Chiari-related syringomyelia. In children, as mentioned by Dominic, we can use the bony decompression alone, but as you can see, we usually use this kind of option in mainly in children, of course, more than adolescents or adults, especially if without syringomyelia. So if the symptoms are mainly related to the Chiari malformation. So in this case, the main advantage is to perform a safe operation. The main disadvantage is the time that this operation takes to be effective. This is an example, for example, for our series. As you can see, we don't have a syringomyelia here. You can appreciate a thin dilatation of the ependymal canal, but this is not the problem. And if you look at the literature, this operation is highly effective if the indication is correct, and also if you are able to check, for example, intraoperatively, as we do with high resolution ultrasounds, the pulsation of the tonsils and the reopening of the subarachnoid space. Otherwise, in case of syringomyelia, the best operation is for sure to perform a bony decompression and a dural decompression. This is mainly speaking only about Chiari related to adult or adolescent patients or children with syringomyelia. And of course, the main advantage of this operation is to recreate the cisterna magna. And of course, the main disadvantage, as we can guess, is the possibility to increase the risk of CSF leakage. This is one case of our series, for example. As you can see, the operation is really effective in reducing the syringomyelia, and also, according to the literature, there is a good improvement of the symptoms, but also of the radiological features, both for Chiari and in particular for syringomyelia. But we know that in children, sometimes the room that we can obtain enlarging the bone and the dura is not enough. So only in these cases, in selected cases, or in case of arachnoiditis, of course, we can also gain more space by performing a lysis of the cerebellar tonsils. Of course, this is the most radical operation, and of course, we can increase some way the risk also of some usually minor neurological deficits. Once again, a case from our series, very good results after surgery and after tonsillar lysis. Once again, of course, this is the most radical, so the most effective operation, radiologically speaking. The clinical improvement is good as well. But once again, the most important aspect, in my opinion, is the indication. As we know, in the literature, there is still such an eternal dilemma by choosing between bony decompression or duroplasty. This is a paper that we published in a special issue that we edited together with Dominic Thompson. And in my opinion, the eternal dilemma doesn't matter anymore, because we know that we are talking about two different techniques that we can use in different subsets of patients. Knowing that the bony decompression alone is safer, it has a shorter hospital stay, a lower rate of complication, but it is less effective. And on the contrary, the duroplasty has a higher risk of complication, but of course is also more effective. So in young children, for Chiari malformation, we consider the bony decompression alone. In the very young, also if they have a syringomyelia. Otherwise, if we talk about syringomyelia, it's better to perform at least a duroplasty. What about the tethering? Of course, in this case, we are talking about syringomyelia related to the tethered cord. And this is a very common, at least a quite common association. If you look, for example, to a general series speaking about tethered cord for different causes of tethering cord, as you can see here, about 40% of children with tethered cord also showed a syringomyelia. And of course, it can also happen in emergency. This is a case we received some years ago. A 4-year-old boy who was admitted in emergency because of progressing paraparesis and urinary block. He was conscious, no particular problem on the brain MRI, but the radiological picture of the spinal cord showed this very large and extensive syringomyelia. That was due, as you can see here, to this very small distal lipoma who was making a significant tetrad cord. In this case, of course, I preferred also to perform such a small direct approach just to deflate the spinal cord that was translucent because of the extreme bulging due to the Syringomyelia. But the most important part of the operation, of course, was the detethering. As you can appreciate, this was the immediate post-operative scan. I go ahead with the movie because of don't have time to show you the movie, the complete movie, but this is the final phase of the operation with the coagulation of the lipoma and the detachment of the lipoma that then was further reduced. And this was the picture at the current follow-up. So, of course, the tethering is really effective in reducing the Syringomyelia. But I'm telling that for the young people who are connected now, don't confuse the tetrad cord associated with the Syringomyelia with the tetrad cord possibly associated with the Chiari malformation. This is one of the last papers published in the literature, where the authors are convinced that those are the only pictures available, that after the detethering, not only the Syringomyelia improved, but also the Chiari malformation. So I don't see improvement. This is the pre-op and the post-op. I don't see an improvement of the Chiari malformation. The Chiari malformation is sporadically associated with the tetrad cord. Of course, they can bring the Chiari and the tetrad cord together, also a Syringomyelia, but the section of the filum terminalis in this subset of patients, I mean Chiari malformation, Syringomyelia, and tetrad cord is a different matter. So you can section the filum to resolve the tetrad cord, but not to resolve the Chiari malformation. This was stated in the study also by in the Brazilian Society of Neurosurgery, and it was clearly affirmed also in the aforementioned consensus conference with an agreement of 100% in the two items. The third possible approach is the direct approach that we use usually in tumor or injury-related Syringomyelia or in case of recurrent Syringomyelia. As you can see, there are tumors mimicking the Syringomyelia. For example, in this paper, it was a subarachnoidoma, or tumors that are clear tumors inducing a Syringomyelia. This is what we usually found in children, very large and diffuse astrophytoma, usually in the dorsal column. In the postoperative, in spite of the good results, we can appreciate, of course, a reduction of the huge Syringomyelia, but also a significant scoliosis. But we can find Syringomyelia that can be treated directly also in a series with post-traumatic Syringomyelia. As you can see, the treatment is various, starting from the compression infusion, in some cases cortectomy, and there is also the syringoperitoneal shunt, for example, independently from the type of injury. This is a case from our series where the Syringomyelia improved after the stabilization and infusion of the patient. This is the pro-op and the post-op. Another example of the direct approach, of course, can be indicated in case of arachnoiditis. Series from the literature, this is one of our cases where after injury we performed also a lysis of the spinal cord, obtaining an improvement. But of course, in this case, we are not sure that this is a definite final treatment in this case because of the higher risk of recurrence. This was the paper that was mentioned by Eans. In case of extreme case of continuous recurrent Syringomyelia, we can perform, for example, a fourth ventricle subarachnoid shunt, or even, of course, this kind of treatment is burdened by a certain rate of complication, as for all shunt, or we can use a simple syringo-subarachnoid shunt. We don't like this kind of treatment, so it is usually reserved for extreme cases. This is one of our nightmares. A 6-year-old girl was treated for chiari malformation and Syringomyelia on 2016 by a bony decompression and duroplasty. She had a transient improvement of the symptoms, but then a worsening, also radiologically speaking, with a significant recurrence of the Syringomyelia. So on 2010, we went back for a new duroplasty and also arachnoid lysis. Once again, we had a transient improvement of the symptoms, but of course, she had, of course not, but she had, unfortunately, a worsening of the chiari malformation and also the odontoid retroflexion. Of course, we had exuded in advance an instability of the craniovertebral junction and, of course, a tethered cord. So we tried to wait and see. In the first month, we were successful because we appreciated a spontaneous resolution of the or reduction of the Syringomyelia, but then a worsening afterwards of the chiari and once again of the Syringomyelia. At the time, we went back for surgery. It was the third operation, and we performed a new duroplasty, arachnoid lysis, and also tonsillar lysis. Once again, we were successful at the beginning, but then we had a new recurrence of the Syringomyelia. So only at that time, we decided to perform a syringosubarachnoid shunt. This is the current picture of the young girl. You can appreciate also the catheter inside the spinal cord, and of course, we hope that this is the last operation for this baby. As I mentioned at the beginning of my presentation, we can have also a fourth option, that is the etiological treatment. We must not forget that in children, we have also this kind of pictures where the chiari malformation and the Syringomyelia are not the primary problem, as we know. For example, in syndromic craniosynostosis, the Cruzon syndrome, where of course the posterior expansion or the whole cranial expansion is the main treatment at the first step. But we can have also this kind of pictures in all the patients. You can see the pre-op and the post-op, especially the improvement, the pre-op and the post-op after the bone expansion of the posterior fossa, which was a case of osteopetrosis. And as Dominic and Federico anticipated, another possibility is the treatment by means of ETT. As you can see here, it was not a significant hydrocephalus in this baby, and but there was a rising intracranial pressure, clinically speaking, with papilla edema. So we went ahead with the endoscopic ventriculostomy. This is the pre-op and the post-op. As you can appreciate, also the fluid collection, the CSF collection around the optic nerves improved, other than the size of the foreventricle, the patency of the ventriculostomy, but in particular, the significant reduction of the Syringomyelia. As you can see here from the date, it was operated in December 2016, the pre-op. The post-op was done in February, so after a couple of months, we can appreciate the significant improvement of the Syringomyelia. So remember that in a subset of patients, the hydrocephalus, that is usually the consequence of the chiari malformation, can induce a vicious circle, worsening the chiari malformation, and in particular the Syringomyelia, and the ATV is successful in this subset of patients in improving both the clinical and the radiological features, both in chiari and in particular in Syringomyelia. This is my last slide, just to remember that, of course, in selected cases, namely those with craniovertebral junction instability, we have the possibility to fix the patients posteriorly, and in really very selected cases, namely those with maintain an anterior compression in spite of the stabilization, of course, also the anterior decompression. Thank you all for your attention.
Thank you, Luca. It was a very nice summary of all the techniques that can be used. And as I said previously, if everybody agrees, we could continue discussing about the management in adults. Marianne, can you introduce us, Andrew? Marianne, you're muted.
Marianne,
yes, I'm on. I just needed to unmute myself. So thank you very much. Our next distinguished speaker will be Professor Andrew Bordwell from the UK to speak to us about management of evolutive syringomyelia in adults. Thank you.
Thank you very much. Can you hear me?
Yes.
And see the
yes,
slides?
Perfect.
Fantastic. Okay, so thank you for inviting me to talk. My name's Andrew Brodbelt. I'm an adult neurosurgeon in Liverpool. And what I'd like to do is just present, I guess, my rather simplistic way of thinking about syringomyelia, my assessment, management, and treatment. It's not as clever as what you guys are presenting, but hopefully it stimulates some discussion. I have nothing to declare. By the end of this 12 minutes, I hope you will have an idea of the principles of imaging, assessment, and treatment of adults with syringomyelia based on the published literature. I've tried to highlight relevant review articles and meta-analyses of interest throughout the presentation. A syrinx is a fluid-filled cavity within the spinal cord, and I don't tend to use the term hydromyelia. I use just the term syrinx for everything. The commonest associated condition is a Chiari-1 malformation. I'm not going to talk about Chiari-2 as that's a different condition, would normally be covered in the pediatric session. So up to half of patients with a symptomatic Chiari-1 will develop syrinx. Traditionally, a Chiari-1 malformation was defined as greater than 5 mm tonsillar descent, but this definition is now outdated. We should think of this as a collection of conditions due to a disorder of CSF dynamics at the craniocervical junction. Patients with syringomyelia may experience a range of symptoms related not only to their syrinx, but also to the underlying causative condition. It's therefore important to take a thorough history and perform an appropriate examination. We've already had very good talks on the sort of things you need to be looking for. A syrinx is the spinal cord's response to a change in spinal fluid dynamics. As such, I agree completely with Professor Thompson. There is no such thing as an idiopathic syrinx. Every syrinx is caused by something, although it may be hard to find. The commonest causes relate to an associated Chiari malformation, trauma, tumors, or some form of arachnoiditic process. Any patient referred with an asymptomatic Chiari should have at least imaging of their brain and cervical spine. If they have a syrinx or the person is symptomatic, then further imaging of the whole spine is required. I'd like to put a plug for Sharon's paper published last year in Brain and Spine, which goes into more detail about the clinical and radiological assessment of patients with a Chiari and syrinx. This 62-year-old man presented with worsening arm symptoms that had been initially controlled with methotrexate by the neurology services. After he started to deteriorate, he was referred to neurosurgery, a scan with contrast, showed a hemangioblastoma, and after this had been removed, his syrinx disappeared. He in fact got better initially, but then a few years later developed progressive problems with his hands. The message here is that all patients with a syrinx need a contrast study. I'm afraid my video images won't play today on the system I'm using, and I'm sorry about that, but static or video images of CSF dynamics and movement can help to identify localized webs or CSF blocks, but are not always available in your local center. So for me, the underlying principles of investigation and treatment, if you have a syrinx in an adult, is 1, find the cause, and we should be aiming to treat the cause. And if that doesn't work, treat it again. And I think, again, agreeing with Dominic, only if that fails, you should be considering a syrinx. Likewise, if we're looking for the cause of the syrinx and a patient has a Chiari, we have to look for the cause of the Chiari. Now, this is a study from Millerat where he looked at over 700 patients in whom they had measured the volume of the posterior fossa. He found that most had a small posterior fossa. There were, however, other groups who did not and still had a Chiari. These could be divided into people who had things from above pushing down, like a tumor or hydrocephalus, those who had craniocervical hypermobility or instability, or other craniocervical abnormalities, and those who had something pulling from below, like a tethered cord or chronic CSF leak from, for example, a lumboperitoneal shunt. Once we have a cause, we need to consider if they need surgery at all. Is conservative management an option with pain management, structured rehabilitation, injections, or drugs such as cannabinoids? Well, if we look in the literature, firstly, we don't know how to predict the natural history of a patient with a syrinx. This review article found 90 patients treated with a variety of physiotherapy approaches in 7 different studies. 3 of these were single case reports. They suggested that this approach can stabilize symptoms. So who should have surgery? In the presence of a severely symptomatic or progressive syrinx, then surgery is indicated. But what about the patient with no symptoms and a large syrinx or a progressive syrinx on imaging? The assumption is that a large syrinx might be causing damage and treatment would be to stop or reduce the risk of developing symptoms in the future. But there's very little evidence that this is the case in the literature, but it is something you need to consider to discuss with the patient. What is our aim of surgery? A surgical success is not just a good scan. Success is also a functionally better patient avoiding complications. Let's start by thinking about a posterior fossa decompression. In 1930, a Dutch surgeon performed the first Chiari operation on a patient with myelomeningocele and hindbrain herniation. This is a photo of him in his operating theatre. In his paper, he stated that he decided to widen the space through which the brain had herniated in order to allow for better flow of CSF. This is still the principle of what we do today. We all know that how we do a posterior fossa decompression is the best way, although we all do the procedure slightly differently. So what does the literature say? Well, a small comparative series suggested that a larger craniectomy provides better early symptom relief, but a smaller craniectomy provides better outcomes in the long term. There's been a lot of debate, and we've been hearing it already today, about bone only, arachnoid sparing, dural opening, and/or patching. A number of meta-analyses, I've quoted Tam et al., suggest that in patients with a syrinx, specifically adults with a syrinx, opening the dura has the highest success rate, but also the highest complication rate. It is a technically more difficult procedure, and patients are in hospital for longer. Bolognese surveyed a group of experienced Chiari and syrinx surgeons, and those with the highest surgical numbers all opened the dura and patched, either with periosteum or bovine pericardium. Other ways of treating post-fossa, decompressive post-fossa, a group from China have published in a minimally invasive way of selectively resecting the tonsils with similarly reported outcomes. And finally, the idea that C1, C2 fixation plays a role here was reviewed by Arslan, but only relatively small numbers have been published, with many having craniocervical abnormalities to a much higher extent that is normally accounted in other series. This treatment remains of interest as the early results are promising, but the pathophysiology, or the reason why it works, remains very unclear. And if C1, C2 instability is the cause of the problem, why does posterior fossa decompression work at all? Up to a quarter of patients following significant trauma will develop a syrinx, and up to a quarter of those will become symptomatic, which can take up to 30 years to occur. A recent review by Yuping suggested that surgery can help with symptom stabilization and motor function, may improve, but pain and sensory symptoms may continue to get worse despite radiologically successful surgery. The DISCUS trial in the UK hopes to examine early spinal cord decompression and fixation after spinal cord trauma, randomized to duroplasty or leaving the dura intact. And it'll be interesting to see if this additional treatment has an impact on future syrinx development in these patient groups. The current accepted treatment of a post-traumatic syrinx involves decompression, dural opening, arachnoid lysis, and often duroplasty with the aim of restoring CSF pathways across the abnormality. Other techniques described include myelotomy and shunting. And we've already started to talk about shunting. Shunting is described from the syrinx to the subarachnoid space, pleura or peritoneum, or simply from the subarachnoid space above to below the obstruction. There's very little in the literature to suggest that one technique is better or provides additional benefit over an adequate decompression and duroplasty. Some patients who develop a syrinx without a Chiari or spinal trauma, imaging reveals an indentation of the spinal cord that resembles a scalpel blade. If present, it is often at the distal end of the syrinx. It may be sometimes better seen on myelography or flow studies. This is the arachnoid web shown here on intraoperative ultrasound. At operation, the band of arachnoid can be divided with sharp dissection and removed. The syrinx usually improves afterwards. However, in my own personal series of patients treated in this way, although the imaging usually improves, the clinical improvement is only evident in just over 50%. In patients with a terminal syrinx and a tethered cord, then the treatment is untethered. This patient presented with symptoms from his syrinx and headache when upright. if we follow the guidance of imaging the whole spine, it means you won't miss the large anterior meningocele. Although this is rare, this that any chronic spinal CSF leak can cause a Chiari and a syrinx, and you need to think about this during your clinical history taking and imaging. Any progressive Chiari should alert you to the possibility of a chronic CSF leak. And as Dominic said right at the beginning, patients with hydrocephalus and a block at the craniocervical junction would normally have the hydrocephalus treated first. If the block is a block in the outlets of the fourth, and I've certainly seen that with people who don't have a Chiari but have a syrinx, then that would normally be the first treatment, to open that block rather than a shunt or an ETV. Let's talk a little bit about shunting of syrinxes. So this systematic review, this time looked at the outcomes of syrinx shunts. The take-home messages are that shunts have a high complication rate, up to 40%. Patients are better. But if you're going to put something in, the syringoperitoneal shunts fared the worst. So think about placing it elsewhere. We've talked a bit about prominent central canals. This is not an early syrinx. This is a variety of normal, and I know, but there's been a publication about using repeated LPs for these people. This is something that you leave alone. If you're really anxious about it, you do a repeat scan in a year, but even that's hard to justify. So finally, take-home messages are, in patients with a syrinx, look for the cause. MR the whole neuroaxis with contrast, treat the cause, and you aim to restore normal CSF dynamics. Finally, I'd just like to put in a plug for the next International Syringomyelia Chiari and EDS conference to happen in Liverpool, June 2025. You've all seen from the recent Eurovision Song Contest what a great place this is. And besides a packed scientific agenda, we're also planning to offer delegates a fun run along the waterfront and a taste of the city. The fun run is not compulsory. We look forward to seeing you in Liverpool, and I'm happy to take any questions.
Thank you very much for this very nice review on the adult world. So now, Martina and Dominic, I don't know if you have questions.
Yeah, we have a lot of questions from participants. Yeah.
Hello. Dominic, who wants to start to discuss the questions?
Well, please feel that I must admit, I'd just like to, so firstly, congratulate Andy. It was a great talk. I would like to do quite a provocative comment that contrast should be given for all patients with syringomyelia. I wonder, is that, I mean, I'm not sure that recommendation would necessarily be substantiated in the pediatric literature, but if you can comment to that, that would be helpful.
I think you can justify it in the adult literature. Certainly, let us say that this is not a dilated central canal, but somebody with a syrinx. I think that you can miss things, and you can, as I've shown by that simple case I showed. So I think, yes, there's a bit of clinical nous comes into it, but I think the bottom line should be, you should always be looking for that cause, as you mentioned, and part of that looking for that cause is just making sure you're not missing a small tumor, hemangioblastoma, or something else. But adults I'm talking about.
Okay, thank you. And one question, if I may, your view in the adult world on the role of CSF flow studies. I mean, where are you currently standing in your practice?
So I think they can help. I think they can help add a little bit to the picture, depending how good they are. So I think we know from the literature that if you're doing a Chiari decompression and there's good flow at the posterior aspect, your Chiari decompression is less likely to work. I use that in patients that I'm really not sure that we should be doing a Chiari decompression, and I use that to say, well, yeah, I don't think that's going to work so well. I think the other place where it can be useful is if you can get good spinal CSF studies, it can help you to find that arachnoid web, which we're seeing more and more in adults and can be really difficult to find unless you're looking for it.
Thank you very much. Martina, please take over.
Yes, just a final remark according to the question whether we need contrast images. So this is sometimes also a topic in pediatric cases. So I remember cases where we had really a kind of hollow syrinx, and due to the void phenomenon you have inside the T2, sometimes you cannot really be completely sure that there is probably not a small tumor in it. And we had a very rare intramedullary schwannoma, which was causing hollow syrinx with repeated bleedings. And this could only be identified with contrast. So I would not say that contrast should not be, after careful evaluation with the radiologist, an option to really rule out the real reason of your syrinx. I think you cannot only judge by the size or the shape of a syrinx alone in selected cases. So probably we should go to the questions. There was a question by one colleague regarding the intraoperative assessment of fluid during the decompression. I think Luca was addressing this topic, but probably he wants to say something about how safe he feels when he is using intraoperative MRI to make an assessment, to be sure that bone-only decompression would be sufficient.
Yes, thank you. I don't have an intraoperative MRI yet, so I cannot answer about the use of intraoperative MRI, except from one famous study that perhaps you remember. It was published 5 or 6 years ago by some American authors. I cannot remember the name. It was not replicated anymore, but they demonstrated that there was a spontaneous improvement in the CSF circulation just by placing the patients in the prone position before starting the compression of the posterior fossa in Chiari patients. So they were questioning about the utility of ultrasounds, of course, since the MRI would have demonstrated a spontaneous improvement just for the prone position. The technique I used and I showed was to perform an intraoperative ultrasound that we performed just at the level of the atlantoaxial membrane before opening the occipital squama. Then we performed the ultrasound after removal of the occipital squama. Finally, after the removal of the posterior arch of C1, and finally, after the removal of the inner remnants of the atlanto-occipital membrane that usually produce the dural ring that, sorry, I have just a noise, the dural ring that compress the occipito-cervical junction. So we have 4 ultrasounds during an operation, and we can appreciate when the compression is enough, really a re-expansion of the cisterna magna, really a fluid film above the tonsils, and in many cases also the pulsation of the tonsils. So in this case, pretty usually occur in pediatric cases, we can be satisfied of the decompression. Otherwise, we go ahead with the duroplasty, but to be honest, usually we plan in advance, of course, duroplasty, not only basing that on the intraoperative ultrasounds, except for some exception when we don't see good pulsation, a good reopening of the spaces.
Okay, thank you. There are 2 questions that could be probably put together. One question is about the possible stabilization, and we have heard that that some groups discuss whether C1, C2 stabilization would be the best option, or as others would say, probably always also including the occiput. And there was another question regarding the odontoid movement, so that we have ventral decompression, which probably has something to do with micro or macro instability. So I would like to discuss the first of all, the probably indication setting in these cases, and on the other side, what is the opinion whether C1, C2? I personally do not understand this mechanism. Should be enough for most of the cases in kind of instability, or if we always should include also the occiput.
Would you like me to talk from the adult side?
Yeah. Please.
Or Luca? Go ahead.
No, please, Andrew, start.
maybe Andrew,
Okay.
because this is also sometimes a topic, the C1, C2 stabilization is more a topic discussed in the adult world. We do not completely understand the rationale behind this.
So I don't think there's much debate if there is definite instability at C1, C2. And if you have basilar invagination and you have a lot of movement there and compression, yeah, okay. If you're going to do a Chiari compression, it's probably not enough. You're probably going to need to fix them as well. And there's been some big studies that show that if you don't fix them, they're the ones that you run into trouble with. If you have just basilar invagination, but it's not there's not movement there, then you're probably okay to just do a Chiari decompression. As far as C1, C2 fixation for everybody with a Chiari, which is what Atul Gol has been suggesting, I struggle with that. I really do. The results, he deals with quite a different population, more pediatric, more children with very abnormal necks. That's not what I see in the adult side. I don't see a lot of people with these basilar invaginations, with these abnormal hypermobile necks. I see many people with Chiaris and syrinxes. So I struggle to take what he says into my own practice, because I think they're quite different populations.
Yeah, so would you agree? Would you agree to say that probably C1, C2 is in post-infectious Grisel cases where we also sometimes have a Syringomyelia? Then we of course have the same principle to treat them. But if we have proven instability at the true CVJ, then probably it's not the best option. So what would you suggest for assessment in order to be sure that stabilization is an indication?
So flexion extension CT.
Yeah.
I don't use flexion extension MR as much, certainly not in these cases, but flexion extension CT.
Yeah, and then you have the problem, C0 down to C2, most of the cases.
So I totally agree with Andrew. Just to answer also a question that I saw about the odontoid retroflexion, this is a quite common feature in finding in children. Usually this is not associated with hypermotility of the junction, so it doesn't mean that the child should be fixed.
Yes,
totally agree with Andrew. And my concern about the Goal technique is that he demonstrated that at least in his hands, in series, is effective. But it is not more effective than the compression for the Chiari malformation. So if you don't have an instability, I don't see a reason to fix a patient, especially a child, so to reduce also the movement of the neck if you have the same results that in cases that are simply decompressed. So this is my opinion.
For sure.
I'm sorry, I need to cut the discussion because
Okay.
Sergey will explain if we are too long. And we'll need to move to the part 3. So Marianne, can you just present the recommendation on the what life should people live when they have a Syringomyelia?
Thank you. Let me just see.
Can you increase the screen?
Yes. Does that show up?
Yes, thank you.
Yes, okay.
Yes, it does. Thank you very much. I have been asked to talk about Syringomyelia recommendations for childbirth and sports. Of course, the reason for lumping these two into the same talk is the question of physical exertion and how that might influence symptoms of Syringomyelia. I have to admit that with this talk, we are moving into quite thin ice because in both situations there's very limited evidence. Now, talking about considerations about childbirth first, it's worthwhile to ask why should we worry about it, and of course it is because the labor and Valsalva maneuvers connected with labor may cause increased pressure of the CSF, And it may also cause pressure differences between intracranial and spinal compartments. And this might secondarily lead to tonsillar herniation, or if you already have it, to increased tonsillar herniation. And that would, of course, be risky for expansion and pressure increase in syrinx. Associated with childbirth is, of course, also the issue of spinal anesthesia and epidural anesthesia, the latter carrying the risk of accidental duropuncture. And this, of course, carries a risk of CSF leakage, which could further increase an ICP gradient and increase tonsillar herniation. So these are the questions that lie behind these considerations. However, as I mentioned previously, there are a few published recommendations. Most of these are actually in obstetric journals, and several of them actually deal with Chiari-1 conditions underlying the Syringomyelia. This is one of the published papers, which is rather typical for the type of evidence that we have. It was published in 2020 in an obstetric journal, and it reports a retrospective study of a total of 83 women, of whom 32 had Chiari without Syringomyelia, so these are not relevant for today, but 22 of them had Syringomyelia associated with a Chiari condition, and 24 had hydro or Syringomyelia, which was non-foraminal, meaning that it was not associated with the Chiari conditions. It's interesting that more than half of them had actually not been diagnosed at the time of pregnancy, so they were diagnosed later. But of the women who had been diagnosed before pregnancy and delivery, 16 had not been operated, and 12 had had surgery before being operated. Interestingly, this reflected in the recommendations for natural vaginal delivery or cesarean section, which is shown in the column diagram in this picture. Amongst all the patients, regardless of the Syringomyelia or Chiari condition, just over 60% delivered vaginally, and about 15% delivered with a cesarean section, planned cesarean section, and just about 20% delivered with an emergency cesarean section. Interestingly, the occurrence of emergency cesarean section was equal among all three groups, including patients with a diagnosed and operated Chiari or Syringo condition, demonstrating that the indications for emergency cesarean section was obstetric and fetal conditions and not related to the Chiari and Syringo condition. So the preference for cesarean section versus vaginal delivery was really the felt recommendations rather than documentations. In patients with a diagnosed Chiari or Syringo condition, it was preferred to have about 35% deliver with a planned cesarean section and under 50% with a vaginal delivery. If they had been operated, even more had an elective cesarean delivery, and very few were recommended to have a vaginal delivery. However, in this paper, there was no clinical deterioration associated with vaginal delivery, nor with neuraxial anesthesia related to this. The paper concluded that neither delivery nor anesthesia modalities affect the natural history, and in fact was not felt to be a risk However, they do recommend that individual evaluation is mandatory, but how that should be practiced is not really outspoken in the paper. If we pick out the syringo cases from this paper, we can see that patients with syringomyelia and syrinx associated had no worsening of their Chiari score. They used a Chiari score, severity score, which they had produced themselves for this particular paper. Interestingly, patients who had what they did called a syrinx only without any CMI, there was a tendency towards worsening of these with a vaginal delivery. And this leads me back to think about Dominic's distinction between a hydromyelia and a syrinx. So patients with a primary spinal disorder underlying the syringal condition might actually do worse with vaginal delivery. A couple of quotations from these papers, from this paper. When asked, neurosurgeons still favored cesarean delivery over general anesthesia rather than vaginal delivery with epidural anesthesia. But surprising, the rate of cesarean delivery increased among women who had already been operated on, although the aim of the decompression operation was actually to decrease the risk of raised intracranial pressure and to increase the flow of CSF across the foramen magnum. So in fact, considering this, these women should be at less risk rather than at increased risk. Further, the paper quotes that given that most patients before being diagnosed had vaginal delivery without any reported neurological complications, so these were the patients who were diagnosed later, we question whether these cesarean procedures were actually necessary. Indeed, there was no statistical evidence for high rates of clinical or radiological deterioration following vaginal delivery with or without spinal anesthesia. And this is, of course, because more than half of these patients had not been diagnosed with their syringomyelia or their Chiari prior to pregnancy and delivery. This is another paper stating more or less the same. And for sake of timing, we should go very quickly through this. Again, a retrospective review of a relatively limited size, 43 pregnancies in 39 patients. They conclude also that it's probably not very risky with vaginal delivery. However, we have to note that 21 of these patients were selected for cesarean section delivery, and only 9 patients in this paper had vaginal delivery. So it seems a relatively slim background for the recommendations that there is no risk associated with vaginal delivery in patients with Chiari conditions. So actually, the most cited clinical reason for operative for cesarean section delivery was the avoidance of Valsalva, which was felt least likely to aggravate the syrinx. However, the 9 patients who did have a cesarean section, they had different conditions, including sensory symptoms, bulbar symptoms, questions of intracranial pressure, motor symptoms, and autonomic symptoms. So these would be exactly the same patients that you would be worried about having a Valsalva maneuver. So it's questionable how solid these recommendations actually are. I think summarizing what is possible to find in obstetric papers, it seems that vaginal delivery and spinal epidural analgesia appear safe but only if the patient is asymptomatic or stable with minor symptoms. The literature we have at hand contains considerable risk of selection bias in the conclusions, because many of the patients who would be at risk actually were pre-selected for cesarean section because of an intuitively felt risk by neurosurgeons and obstetricians. This paper in ACTA, a recent paper in ACTA, presents the neurosurgical view of the scenario, and they state that there were no instances of brain herniation during surgery during pregnancy in patients with Chiari conditions, and they had did an additional literature review where they found that across all the publications they found, there was only one case of worsening of neurological symptoms in a patient with a prior undiagnosed Chiari-1 malformation. They also found that cesarean deliveries were and vaginal deliveries were about 50-50, including those with a neuraxial blockade. And the number of patients who had undergone occipital craniectomy to treat the Chiari, most of those had actually done that in the preconception period before they were pregnant. They had found very few instances of patients undergoing decompression during pregnancy or even after birth. So they concluded that the evidence is limited. And although devastating complications could be feared, the actual literature contains very few adverse events. And to support our own conclusions here, they state that patients who are truly asymptomatic could probably recommend it for vaginal delivery under normal conditions, but with a recommendation to limit maternal Valsalva efforts. And they also recommend that patients who have significant neurological symptoms prior to conception should probably undergo a decompression if they consider pregnancy. But sometimes, as you know, this may be too late because you may become pregnant before you know you have a Chiari and before it's possible to undergo a decompression. So this is sort of a very hindsight-like conclusion. Turning on to Syringomyelia and sports, the evidence is even slimmer. I found this case report from 1974 stating that a young athlete during squat exercises with heavy weights on his shoulder became symptomatic with a tetraparesis, and he turned out to have a Syringomyelia in the cervical region. Another case of heavy weightlifting, again a single case report, concluding that repeated Valsalva maneuvers from daily very heavy weightlifting exercises probably predisposed this patient to development and extension of his Syringomyelia. It's not possible to know whether he actually had it in the first place and whether he then had the Syringomyelia and became symptomatic due to this. There are a few reviews, including this one, recently published in, or relatively recently in 2012. They conclude that many spinal anomalies are actually detected as incidental findings. And if the incidental findings are minor, for instance, a minor Chiari with a hardly visible cerebellar descent, or very small dilatations of the central canal being normal parts of development, are normal and should not require further assessment or restriction in sports. They further conclude that patients with a significant Chiari malformation and Syringomyelia should be assessed by a neurosurgeon, but the data on contact sports and heavy exertion sports are very limited. Again, this publication about asymptomatic Chiari-1 malformations, where the patients should be advised against participation in contact sports, was the only thing I could find coming close to recommendations for asymptomatic Syringomyelia. Again, they state that conditions like this are very often found in asymptomatic patients as incidental findings. There are single case reports of sudden death or sudden neurological injury following head and neck trauma, raising the question of contact sports. But performing a literature of a review of the literature, they could find only single case reports, no series, and they found in total 21 case reports of patients deteriorating following trauma, but they could find no large studies or no large series, and they felt, based on this, that in general, patients with Chiari-1 conditions should not be recommended for restriction in sports. So in the end, this is quite flimsy evidence to sum up. So because the literature is very scarce, there are only case reports, no clinical series. All the case reports are proband cases with an injury and with a Chiari conditions. Based on this, it's actually not possible to assess what the subsequent risk is in a Chiari cohort who participate in sports and who have trauma. But the risk is probably low given the very small number of reported cases of worsening of Syringomyelia and Chiari symptoms following trauma or sport. So contact sports by themselves probably do not present increased risks of worsening or becoming symptomatic, but persons with significant symptoms could, of course, have increased risks of sports that involve extensive neck movements. But a priori, patients who are significantly symptomatic from Chiari or syrinx conditions probably are much less likely to participate in contact sports in the first place. However, it would seem that heavy weightlifting might propose a particular risk, and this is probably the only type of sports that one should particularly discourage patients with these conditions to participate in. And this was the last slide. Thank you for listening.
Much, Marianne. So I think you nicely summarize the lack of literature and studies that we can base on which we can base our reflection, because indeed, though it is quite a common situation, as we have seen with Dominic and all the other speakers, to find some kind of hydromyelia or other images. At the end, the cases in which there is a symptomatology worsen after contact sports, it's very few. So probably, as you said, it's a normal life for all these patients without medicalization. You raise your hand, Andrew. So maybe you want to comment?
May I ask a question?
Sure.
Marianne, really enjoyed your talk. Do you think there's a role for the joint pediatric and CSF sections to put together a statement on the management of the proposed advice for patients going through delivery with the Chiari and a syrinx or the use of contact sports? Because like you've shown, it's a very disparate field, literature, and there's little bits everywhere, and it might be nice if the section thought about it. I'm just throwing it out there as a question.
Oh, thank you for this question. And I must admit that I was quite frustrated going through the literature. I think your suggestion is really worth the while. Going through the literature and preparing my lecture, I came to think about a question I had in a similar condition, which was a young man with a coincidentally found arachnoid cyst, who was going to become a professional soccer player. And I was asked both by him, his parents, and the soccer club what the recommendations would be for a soccer player with the use of the head and neck when you hit a ball with your forehead. And it was also extremely difficult to find a good basis for recommendations. So I think what we can sum up of the literature and what we can do to propose any type of recommendations would make people feel more secure. However, I must emphasize the need for individual assessment in each particular case, and advise against such recommendations being used as a safe shield to hide behind.
The question is the following. Sometimes the parents of children with asymptomatic Chiari and asymptomatic Syringomyelia ask pediatric neurosurgeons if it is possible for his child to go in for sports, for example, gymnastics or football. So what may be the answer to this question?
I think I would rely very heavily on Dominic's talk and think about some of these are actually truly incidental findings that do not need any intervention and that are not that are hardly likely to progress and should not cause any type of worries, versus patients who have a condition that is a pathological condition that would require at least a follow-up and maybe some recommendations for, shall we say, sports with very heavy exertion and strong Valsalva maneuvers. But Dominic, how would you address this question?
I must admit, I tend to be very liberal. I think, as you've pointed out, you try and search the literature, and I think if there were lots of people being injured as a result of doing sports with Chiaris, there would be something in the literature. And I think the social benefits, the health benefits for kids under doing sport, I think vastly outweigh the restrictions. And so I must admit, I tend to be very liberal in all the kids actually in terms of them doing sport.
I was thinking about the, shall we say, statistical coincidence in both terms of childbirth and delivery versus sports. And I was wondering why there were, although flimsy, still more literature about childbirth. And the reason I thought was that pregnancy and delivery is hugely common among at least among half of the population. Most women undergo pregnancies and deliveries. So coincidentally, some of them having a syringomyelia and needing that kind of advice is a relatively common thing. So the overlap between a very common thing and a rare thing is going to occur, whereas trauma is much less common than pregnancy and delivery. So the overlap between a rare condition like Syringomyelia and Chiari and some sort of injury is much less common than the former. So I think it will be very hard to gain any sort of statistical evidence, solid statistical evidence to support our recommendations. Turning back to what you suggested, Andrew.
Luca, you raise your hand.
Yes, thank you. Very quickly. Totally agree with Marianne and sorry, and a problem maybe. Okay. And Dominic, because of course in the literature we don't have many studies about, or we don't have studies about Syringomyelia, but we have several studies with 300, 400 cases each for chiari malformation and spots, especially in the United States. And this study demonstrated that there were no correlation between injury during sport and chiari malformation. And they took into consideration not only tennis or swimming or soccer, but also American football or rugby, so that are contact sports. So we can have some conclusion to give to our patients that Marianne was saying, and also Dominic was saying, about children who are, or also adults who are really asymptomatic. The problem may be the Syringomyelia, non-evidence, and the problem may be the delivery, but we have some evidence also about the delivery, as Marianne showed. And in Italy, with the Italian consortium with chiari and Syringomyelia, we are working on that, just to, of course, not to provide guidelines, because we are not able to do it, or recommendation, but to ensure the patients. Maybe the first step we can do is that suggested by Andrew, because this is the way to increase our knowledge, so we can contribute, of course, to this kind of project.
Radek, do you have a comment?
Thank you. Thank you for nice reports, everyone, and specifically Marianne. I just sitting and wondering that the funny thing is that the same kind of questions we get regarding all many other pathologies like arterial cyst, vascular malformations, and the funny thing is that the incidence of these incidental findings is approximately up to 1% of the population, and with increasing number of MRIs that are taken in Western countries, it's quite a huge amount of referrals. We get literature every day. So I think I support absolutely the view of Andrew. It would be very nice to aim at having some kind of consensus that could be used until we have more knowledge and more evidence, because otherwise, we all will drown in the referrals from GPs and from other colleagues and from the population, because the incidence of these findings has just increased enormously, at least in Western countries.
Incidentalomas is more and more an issue.
Yeah.
Increase, and so there are more and more vomits, to remind the acronym, victim of modern imaging technology. So I think we need to close here. We are only 10 minutes late. So Sergey, it's much better than last time.
Yes.
Well done.
If possible, I may say some words in the conclusion.
Yes, please.
So, first of all, on behalf of the ENS Pediatric Section Board, let me thank all the prominent speakers, the respected moderators, and the very attentive and active participants. So I would like to stress that the concept of this session was elaborated by Federico, so and only slightly revised by me. So today we had a great audience, more than 180 participants, and I hope it will be the same or more on the next webinar. Sometimes many questions from the participants about the possibility to again look through the recordings. Yes, the record of this webinar will be published on the ENS site. Yes, Anna, you are with us? Yeah, as far as I know, all these webinars are recorded and then are available for the registered participants. So, and the next our webinar will be devoted to the vascular pathology in children, which is quite different from the adults one. So this is a provocative question, and we are going to answer it. So many well-known speakers will be involved in the next webinar. Andreas Raabe, Radek Frick, Peter Vaikochi, Marco Cenzato, Sergei Yakovlev, and Yuri Pilipenko. And some others will take part in the next webinar devoted to the vascular pathology. So, and as I have told you, please follow our advertisements because the next webinar will be devoted to the question gliomas in adults and children disease. So this is joined with neuro-oncology section, and the treatment of cerebral palsy joined with the functional section. So, and looking forward to see all of you on the next webinars, and I wish everyone peace. Thank you.
Thank you very much. Thank you. Bye-bye.
Thank you.
Bye-bye.
Bye-bye, everybody. Thank you.
Bye.